A 47-year-old male, a businessman by occupation, came from Salem with chief complaints of diminution of vision in the left eye since childhood, with increased diminution of vision for the past 7 months. History of presenting illness. The patient noticed gradual onset, painless, progressive diminution of vision since childhood, with increased diminution of vision for the past 7 months. It was not associated with glare. It was not associated with redness, watering, photophobia, or colored halos. There was no history of spectacle use, no history of ocular trauma, no history of headache, no history of nocturnal awakenings or breathlessness, no history of steroid medication use, no history of blindness in siblings or any other family member. The treatment history, the patient had consulted elsewhere and was told to have high pressures in the left eye and was started on 3 topical medications for the left eye, that are bemetoprost eye drops once a day, timolol eye drops twice a day, and dorzox eye drops thrice a day in the left eye, and bemetoprost eye drops once a day in the right eye. There was no history of ocular surgery or laser procedures. Medical history. He is a known case of type 2 diabetes mellitus for the past 6 months on medications. There is no history of hypertension, bronchial asthma, or coronary artery disease. Personal history. There was normal bowel and bladder habits, regular sleep cycle, no history of smoking or alcohol intake. On general examination, the patient is conscious, cooperative, well-oriented to time, place, and person, well-nourished and moderately built. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. On systemic examination, the CNS, there were no focal neurological deficits, CVS S1, S2 present, no murmurs, respiratory system bilateral normal, vesicle of breath sounds present, and broad abdomen was soft and non-tender. Moving on to the ocular examination, head position was erect, facial symmetry was maintained, eyeball position was orthotropic, extraocular movements were full and free. On ocular examination of the right eye, the uncorrected visual acuity was 618, improving to 6.6, and near vision was N8. On refraction, there was -3 diopter spherical and -1.5 diopter cylindrical power at 90-degree axis, improving to 6.6, and a near-add vision of +2 diopter spherical, improving to N6. There were elongated eyelashes noted. The rest eyelids were within normal limits. Conjunctiva of the right eye was normal, sclera normal, cornea was clear, there was no evidence of pigments, anterior chamber depth was Von Erichs grading 3 and it was quiet. On iris examination, normal color and pattern, there was no evidence of neovascularization of iris. Pupils 3 mm D plus C plus brisk, lens was immature senile cataract, NS1, and intraocular pressure by Goldman applanation tonometer was 13 mm Hg on 1 topical medication. This was a slit lamp examination of the right eye, the diffuse and the slit image. On gonioscopy using 1 GM mirror, based on modified Schaffer's classification, on all the 4 quadrants it was open and there was no evidence of PAS or pigmented Schwalbe's line or neovascularization of the angle present. This was the right eye fundus examination. Right eye media was clear, the disc color was normal, margins were defined. The size was 1.69 after applying the correction factor of 1.3. The cup disc ratio was 0.3:1. The neuroretinal rim was healthy. There was no evidence of peripapillary atrophy or disc hemorrhage or RNFL defects noted. Rest vessels and periphery were within normal limits and foveal reflex was present. This is the diagrammatic representation of the same. Moving on to the left eye examination, the uncorrected visual acuity was 360 PR accurate in the left eye. The near vision was N8. On refraction, there was -15 diopter spherical and -3 diopter cylindrical at 70-degree axis, improving to 618. The near add vision was +2 diopter spherical, improving to N6. The elongated eyelashes were noted. The left eye conjunctiva was normal, the sclera was normal, the cornea was clear and no evidence of pigments. Anterior chamber was Von Erichs grade 3 and was quiet. Iris was normal in color and pattern. There was no evidence of neovascularization of iris. Pupil was 3 mm D plus C plus brisk. Lens was immature senile cataract with a grading of NS2. And intraocular pressure by Goldman applanation tonometer at 10 AM was 30 mm Hg on 3 topical medications. This was a slit lamp examination of the left eye. On gonioscopy using 1 GM mirror, using the modified Schaffer's grading, all the 4 quadrants open angles were noted and there was no evidence of PAS, pigmented Schwalbe's line or NBA. This was the left eye fundus examination. The media was clear, the disc color was normal, the margins were defined, the size was 1.69, the cup disc ratio was 0.8:1 with neuroretinal thinning in the superior and inferior. 360-degree peripapillary atrophy was noted. There were no evidence of disc hemorrhages or RNFL defects. Rest vessels and periphery were within normal limits, and foveal reflex was present. There were no features suggestive of myopic fundus. This was my left eye diagrammatic representation. So on summary, 47-year-old male with complaints of left eye gradual onset painless progressive diminution of vision since childhood, on presentation with a BCVA of 6.6 in right eye and 6.12 in left eye, with left eye high myopia and rest anterior segment within normal limits, with an intraocular pressure by Goldman applanation tonometer of right eye 13 mm Hg on 1 topical medication and left eye 30 mm Hg on 3 topical medications. And the fundus examination revealed the cup disc ratio of 0.3:1 in the right eye with NRR healthy, and left eye cup disc ratio was 0.8:1 with superior and inferior NRR thinning. So my provisional diagnosis would be both eye immature senile cataract with right eye ocular hypertension with left eye primary open angle glaucoma with type 2 diabetes mellitus. Thank you.
Yes, Snehita, you have presented well. So just from the history, I want to ask a few questions. So why did you ask for history of trauma?
Ma'am, trauma can also cause glaucoma, ma'am, like angle recession glaucoma. So we are just ruling out the causes of glaucoma because the presentation is 47 year and no family history is present.
And moreover, what is the other reason? Like, is it more like an unilateral glaucoma?
Yes, ma'am, unilateral glaucoma, but right eye is ocular hypertension. But because it's a unilateral, we have to rule out trauma cause also.
Especially in asymmetrical cases, you have to rule out trauma. So what about the history of headache? Why did you ask that?
Ma'am, headache history can be due to the accommodative spasm which might be present in glaucoma patients, and also sometimes an angle closure glaucoma. Some patients might present with headache. They might have a discrepancy between the peripheral visual field loss and the central vision which is present, ma'am. So that discrepancy might cause headache because of accommodative spasm.
What are the symptoms of primary open-angle glaucoma?
The patient will have painless gradual loss of vision. Otherwise, it's asymptomatic only,
Yes,
ma'am.
mostly asymptomatic. So the angle closure eyes, especially the creeping angle closure, chronic angle closure, so they might have some acute, some subacute attacks. So that could manifest as headache. So you're ruling out that.
Yes, ma'am.
Okay. So what about you have asked for history of blindness in siblings?
Yes, ma'am.
So
Actually, like if family history is present and if siblings are having glaucoma, there is 9% risk of glaucoma in the patients now. And any other family member, like parent might have, means 5% risk is there of getting the glaucoma. And also juvenile open angle glaucoma can be ruled out because the age is 47 years. So a risk of, it might be even juvenile open angle glaucoma, but the strong family history is not present here.
yes,
Dr. Parthiban here. Subhashini, can I ask a question?
yes, sure, sir.
Doctor,
Yes, ma'am. Yes, sir.
family history is strongly relevant with what kind of a gene? What are you looking at?
Sir, in POAG, sir, or juvenile.
Yeah, in POAG.
If it's like associated with the subset of juvenile open angle, we can look at myocilin gene or optineurin, CYP1B1.
Okay, so myocilin gene, these type of people are positive for myocilin gene. What is the real exact presentation like? What's the significance of people who have a myocilin history, a family history of myocilin?
I'm not sure, sir.
Any idea about the onset? Do they occur at an old age or a young age?
Young age only, sir, early on.
Yeah, it's a very strong family history of myocilin genes, which present very early in the thing. So people with developmental glaucomas, juvenile glaucomas, I think all of them should be screened for your genetic study of myocilin genes. There's a separate entity which is very strongly caused in the family.
Slide share. You can stop slide share.
So you can go to the examination actually. Go.
1 minute, Madam Parthi.
Yes.
Let Madam finish and then we can take over.
Oh, fine.
Thank you.
I'm so sorry.
No problem.
No issues. So you can go to the next slide. So you have told about pupil examination. So since this is an asymmetrical glaucoma, so did you do anything else?
Just we checked RAPD to rule out any trauma history, like
Was there
traumatic
not
glaucoma.
RAPD in this case?
No RAPD, ma'am. And also in advanced glaucoma, they might present with RAPD, but there was no RAPD in this case.
You should especially look for RAPDs in the asymmetrical cases.
Yes.
And go on to the next, the fundus examination. So how did you do your fundus examination?
Ma'am, first, after doing the gonio, we'll proceed with the fundus examination with dilation of the pupil. Undilated also, we can see using 90D examination to look at the
90D
cup.
examination. You didn't mention about the 90D, but you applied the correction factor. So it's
Yes,
90D examination.
Yes, 90D
Yeah.
exam.
Besides the in the neuroretinal rim, what all you look for?
Ma'am, I look for the color. First, we'll look for the size, ma'am, whether it's thinned out in superior, inferior, the nasal or the temporal quadrant. And then we look for the pallor. If it's very pale, it might point towards advanced glaucoma. The loss of more retinal ganglion cells.
If there's pallor of the neuroretinal rim, what else?
Advanced.
Oh, can it be glaucoma or something else?
It can point towards other disc pallor causes also.
Yeah, optic atrophy also
Optic
can
atrophy.
have cupping.
Secondary glaucomatous
Yeah,
optic.
so the mentioning the color of the neuroretinal rim is very important, besides telling whether it's healthy or thinned. Then your diagnosis is right eye ocular hypertension. Why did you say ocular hypertension?
Ma'am, because on the first presentation, like where he consulted outside, the IOP was high, around 24, and he was started on one anti-glaucoma medications, after which the IOP is controlled. The IOP is high with optic disc within normal limits, and visual fields are also normal, so it's more pointing towards ocular hypertension.
So why did the patient develop advanced, the glaucoma worsened in the left eye? What is it?
Because left eye is having more of myopia. So in myopia, there is because there is axial length increase, there is more elongation, and lamina cribrosa is more prone to ischemia. So even normal pressures might cause disc cupping. And also that optic nerve head is more prone in cases of myopia, ma'am, because of the axial elongation.
What are the other
Glaucoma.
presentations of high myopia?
Ma'am, in high myopia, we will have axial length increase. There is thin sclera, and their myopic fundus presentation like
Can they have normal tension glaucoma?
Yes, ma'am. Normal tension glaucoma, important risk factor is high myopia, ma'am. And other myopic fundus picture like posterior staphyloma or the lacular cracks.
Myopia itself is a risk factor for
glaucoma. Yes, ma'am.
Risk factor for glaucoma. So can it be protective? Myopia can be protective for certain conditions.
Angle closure glaucoma, its hypermetropes are more prone, ma'am. So
yeah, okay. Angle closure does not occur. The chamber is deep. No, protective for other ocular conditions. Myopia. This patient has been diagnosed as a diabetic, no? Yeah. So
retinopathy.
Yes,
retinopathy is protective.
Yeah, diabetic retinopathy, ARMD, non-arthritic AION, all these do not occur in moderate to high myopia. So what do you want to do for this patient? So now you have made a diagnosis.
Yes, ma'am. So first, for the right eye ocular hypertension, we'll be continuing the same anti-glaucoma medication because the IOP is controlled with that, and we have to frequently monitor the IOP as well as the fields. Whereas in left eye, because of the very high IOP, 30 mm Hg on 3 AGMs, and also a significant NS2 cataract, it's better we go in for a phaco.
Measures are not controlled with 3 medications. What is the first thing you think of?
Advanced glaucoma.
No, first, what do you ask the patient?
Like whether he is using compliant with the medications.
Compliance is the important factor. You just simply do not keep adding drugs without realizing whether the patient is compliant or not. What is one method of finding out if the patient is compliant?
First, we can ask the patient, like, how is he using the drops, whether he's demonstrate whether the way he is using the drops and explain him about the double dot technique. about
Correct.
using the drops properly.
Yeah. So for chronically, if the patient has been using, so what else you can check to find out if the patient is using the drops properly?
Ma'am, like if in the complications, like because of prostaglandin
Yes.
analogs, there might be elongated eyelashes,
Yeah, so the
hyperemia.
patient and the long lashes, that itself will indicate whether the patient is putting the drops properly or not. So in for the right eye would be monitoring, and for the left eye, what do you want to?
Because of the NS2 cataract and also the high pressures, though the patient is using the drops properly, we can go in for a phaco trab, ma'am, to control, to do it in one sitting,
The
both the
patient does
cataract
not
surgery.
want surgery. What can be done?
If because it's advanced, there's nothing.
A patient wants it later, so you want to control the pressures. What can be done?
Lasers can be done,
Yes.
but it won't be that effective. But we can give a trial of SLT
Yes. So
for
now,
left eye.
what you have to be wary about in high myopes, in those people when you do a trabeculectomy post-op?
Uh, during trabeculectomy itself, because of the very thin sclera, ma'am, the sutures might not stay well. So we have to clearly monitor the IOP, and also the suturing should be tight because there is increased risk of perforation and necrosis, and also the antimetabolite used intraoperatively should be used judiciously because it might lead to scleral necrosis. And post-op IOP monitoring is required. In case the IOP is high, we might need to do suturolysis accordingly, ma'am.
Madam, can we move to the
Oh,
external
yes,
examiners,
yes.
madam? Yeah, thank you.
I'm
You
done.
presented very well, Snehita. I'll come
Thank
back
you.
to you. Now over to the. You
One
can
second,
stop share, madam only.
Yes, yes, she can
Madam, to
stop.
you only.
No, let her continue. That sharing business I want.
Stop. You want, madam?
Show me that vision part.
Hmm.
Show
Sorry,
me
ma'am.
Yeah, it's
vision part.
better at the
Slide share.
there.
I say vision.
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 Go to the examination.
Vision, you say you have written here that the near vision is N8.
Yes, ma'am.
Okay. If you check this patient for near vision without any glasses, what will be the near vision?
This was like checked without glasses only, ma'am, but it should be lesser only. But since myopia is there,
Less means what? Yeah. Yes. Myopia is there.
index myopia will cause improvement in near vision, ma'am. So the patient without glasses only read N8, ma'am.
No, doctor. -3 and -1.5 cylinder also is there. No, then the patient would have read N6 because you're saying that with add of +2 he is having N6. That
Okay.
means even
Madam,
without correction.
we're not able to hear you, madam, clearly.
Can you hear me now?
Yes, yes.
Yeah, yes.
Even without correction, the patient would have had N6.
Okay.
Both eyes. Other eye also you have written with +2 add N6 is there. So this patient would have had N6 vision without any correction.
Okay.
Okay. With that, the examiner will find out that you haven't checked the near vision without correction. So you must be careful.
Yes, ma'am.
Okay. That is why I wanted this slide to be. Okay. Now you can take off that slide sheet.
Yes.
Oh. Madam, any other question?
Yeah,
You
no.
can
I
ask
have
one or
one.
two questions to all the three moderators first, and then
Okay,
Srikanth can
one
add.
more question. One more question.
Yes, ma'am.
See, you have told that there is no history of any steroid use.
Yes, ma'am.
Okay. See,
Yes, ma'am.
in many Ayurvedic, Siddha medicine and all, no, they
Yes.
use steroids. They won't tell, but they use steroids. So you must make sure, because I have seen posterior subcapsular cataracts appearing in patients who say that they are using Ayurvedic medicine for their asthma.
Yes, ma'am.
So you must be careful about that also.
Yes,
Okay, there may be steroid use in that. And how long has the patient been using these eye drops?
For the past 1 year, ma'am.
1 year. Okay. So you said the eyelashes are longer, no? So I want to know
Yes, ma'am.
when exactly this. And there is no difference in the size of the eyeball between the two eyes. There is no difference in size.
No, ma'am, it was not significantly noted, but in biometry alone, the axial length was increased. This side was 23, that side was 26. When looking clinically, it was not seen.
Okay. And I'm surprised he was not using glasses for such a long time.
Because of
And you must think of frequent change of glasses in primary open angle glaucoma. Frequent change of glasses. That is one more history you should ask.
Frequent change of presbyopic glasses, more
Yeah.
precisely.
Okay.
Thank
Okay.
you, madam.
Probably.
Parthiban,
Yeah.
your video is off, Parthi. Okay.
Doctor, is there any role for MIGS in this case?
No, sir, because the left eye is showing very high pressure. We can give a trial, but it will not be successful as trabeculectomy, sir.
Do you
But
think
since
a
we're
MIGS has a
combining,
greater role to play when you have a cataract, along with cataract?
yes, sir, along with cataract, MIGS works better than trabeculectomy. But
Yeah.
since the pressures are very high, 30 mmHg, we went in for trabeculectomy.
30 is not very high. What was she on? What medication was she on?
All three medications, sir, prostaglandin, Dorzox, and
Okay.
yes.
So this is, what do you consider this? Is this a maximum tolerated medical therapy or a failed medical therapy? What do you do? What do you consider this as?
Maximum tolerated medical therapies.
Okay, don't you think a surgical procedure of MIGS will be the ideal choice for a person with a cataract?
Yes,
I
sir.
would suggest
Yes.
a MIGS procedure rather than a topical medication, putting the patient on a long term.
maybe GAT would be a good procedure. Other procedures might not be that effective. So GAT.
Yeah, sutural gap will be a much better choice. Thank you.
Thank you, Parthi. Thank you.
Just one more thing, Chandrasekhar.
Yes.
Dr. Snehita, one more reason for doing surgery in this patient is this gross difference in the power. No, one is
Yes,
minus
sir.
15. For
Other is
that also, you would prefer to do a surgery.
surgery. Yes.
So, Dr. Kavita, madam, you want to ask anything?
Very nice presentation, Dr. Snehita.
Thank you, ma'am.
Just wanted to know whether you did visual field examination for these patients.
Yes, ma'am. Visual field examination was done, ma'am. Right eye showed. You want me to share that?
Yeah.
But left eye had actually high fixation loss, ma'am. So the printout is not available. Right eye was available, ma'am.
So you have made a diagnosis of primary open angle glaucoma on the left eye, and right eye you say it is
Ocular hypertension, ma'am. Yes, ma'am.
So why do you say it is ocular hypertension on the right eye?
Yes. The IOP is more than 21 mmHg on two baseline values without any optic disc changes or visual field changes, ma'am. I'll just show the. And only one baseline C fields was done, ma'am, in right eye. The left eye had high fixation loss, so the field is not available on that print.
Okay.
Okay. You can stop share, ma.
Right eye can be.
Yes.
Yes, madam. Yeah, go ahead.
So right eye, don't you think it can be a normal, and can you think this left eye glaucoma can be a secondary cause of, secondary glaucoma instead of primary open angle glaucoma? Because only two readings, it was, you said it was high. When was the patient always on topical medication?
Ma'am, but for the past 1 year, he was on the topical medication. It is controlled, ma'am. Maybe we have to stop the medication and repeat the IOP, do IOP monitoring and repeat the fields also to confirm. But for now, we have diagnosed as right eye ocular hypertension.
Because very often when there is a glaucoma on the one eye, we tend to treat for both the eyes. But most often it may be a secondary cause as well. Secondary cause of glaucoma. So what are the investigations would you suggest?
First, we'll be doing central corneal thickness, ma'am, because generally in myopes, there is thinner corneas.
Patient other than the ocular evaluation, what are the other systemic evaluation?
Systemic, because myopes are more prone for NTG, ma'am. We can do that monitoring of SpO2, that sleep apnea is one important risk factor for NTG. So we can do that oxygen pulse monitoring in the night. And other than that, systemically, we can look for hypertension and nocturnal hypotension, which might lead to ischemia of the optic disc and cause glaucoma as well. And
okay, ma, can we move on, madam? We have taken a lot of time for the first case.
Nice.
I want to make only 3 comments, not a fault finding. One, you either get dilated pupil or constricted pupil. not you can dilate and see in the exam. And you just
Okay.
tell what you told about your pupil. You tell your pupil.
Both eye with both eye was
No,
3
no, no,
mm,
no.
direct
Right eye,
and
left. Right eye, you tell.
3 mm, direct and consensual was present, sir.
Equally reacting
Left.
to both direct and consensual. That should be the way. And you have to make your presentation as constricted only or dilated. If you're dilating, then your angle may not be correct. There could be
Okay,
crowding.
sir.
So you remember this, and you do not know that the fields has been done, anti-glaucoma surgery has been done. So in the exam, you won't have any. And what was your diagnosis? I'm going to comment only. Your diagnosis is not complete. You have not mentioned about the myopia part. Always remember, refraction is also part of the diagnosis. One advice is right separately, right eye separately, and left eye separately. So you'll never
Okay, sir.
miss. So this
Yes.
just a few points from the example. You made a very good presentation, and thank you, Subhashini, madam.